Hello, everyone, and welcome to Move Daily Fitness. I'm your host, Tracy Steen, and today on the podcast, Dr. Carrie Jones. This lady, she caught my eye over on Instagram probably a year or so ago because she has a very humorous approach to this whole phase of life. I think in a space that is really overwhelming right now with a lot of opinions, bringing some humor to the game is a good idea, and she does exactly that. Carrie is also an internationally recognized author, speaker, consultant, educator on the topic of women's health and hormones with over 20 years experience in the industry. She's been dubbed the Queen of Hormones. Is that a title you want? I don't know. Yeah. You know what? It's good to know about them, and she does. Dr. Jones is a naturopathic physician who did her 2-year residency focused on women's health and endocrinology. She went on to get her master's in public health and was one of the first to become board certified through the American Board of Naturopathic Endocrinology and is a Menopause Society certified practitioner. She's also got a podcast called The Root Cause. I'm definitely going to be asking her why she called it that and what the root causes are that we need to be looking out for. She's going to be a fun guest to interview. Welcome with me, Dr. Carrie Jones. I want to start by asking you this question. Okay, ready?
I'm ready.
I'm ready. Okay. What do you love about what you do for a living?
Oh my gosh. I love that I get to educate women about their body because I find, and I have found in my 20 years of experience, so many just don't know. And I love that it still doesn't get old when I meet people for the first time and they go, "What do you do?" And I said, "I'm a women's health and hormone doctor." And they're like, "We're about to be best friends." I'm like, great. I love that I get to explain things to them. I love that I get to describe what the hormones do, how their body is functioning, what's going on. And I don't even mean in a patient setting. I mean, just in the average everyday woman I talk to on social media. I never find it boring. I never find it that I'm burnt out. I get tired, but I don't get tired of this.
Yeah.
And that's what I love. I love that it makes me sad women haven't had this education historically, but I love that I love it and I get to do it.
You must have just developed a whole protocol on how you have these conversations with women now because yes, 10 years ago, 15 years ago, there wasn't so much information out there as there is today. And so what kind of conversations are you having in the doctor's office on these topics?
Straight up conversations. I'm a very blunt, straight up, funny type of person. So I don't get embarrassed by the awkward conversations. I want women to understand what's going on with them biologically, physically, medically, emotionally, all the things. And I developed that reputation really pretty quickly when I was seeing patients full time. And as a result, they would refer their sister, their coworkers, their neighbors, because they were like, "You have to go see Carrie. She just tells it like it is." And I find because we didn't get told how it is for so long, and the number of times I've had women say to me, "My doctor just wouldn't have that conversation. They didn't want to talk about the taboo subjects or the symptom that I'm having that's kind of embarrassing." They were embarrassed. I was like, "No, we can't do that. We have to be straight up. Like we have to call it what it is, and we need to talk about it, and we need to cover it in today's visit." So we would talk about everything from sometimes it was just a full, like a counseling appointment. We were talking about marriages. We were talking about trauma. Sometimes it was embarrassing vaginal symptoms. Sometimes it was like, my night sweats are so bad, I'm soaking through my sheets. Sometimes it was fertility things that they just didn't understand truly how to make a baby. The number of grown women who said to me, like, I know we have to do it, but I don't know how to do it or when to do it, like the timing to do it. And I'm like, yeah, because it's not very well taught. I've had young women ask me to explain sex to them because they didn't feel comfortable looking on the internet. They didn't feel comfortable asking their parents. They surely didn't learn in school. Like, okay, yeah, let's sit down and have that conversation, explain what it means. And it never bothers me. Have had suicidal conversations with lots of patients. And that's what we need. We need that straightforward, here's what's going on, no joke discussion.
Yeah, absolutely. And this is what drew me to you as well is in your podcast, in your conversations, you really do talk about this multifaceted approach to wellness. It's
Yeah.
not just about let's check out your hormones, maybe or maybe not, recommend hormone therapy, and it's just like, in a silo. It's everything, isn't it? So
It
let's
is
talk
everything.
yeah, let's talk about that a little bit. What are some of these pillars, some of these foundational things that as we're entering this phase of our journey, what do we want to be paying attention to a little bit more?
It's funny. I am, part of, either I don't know what you call it, integrative, functional, alternative type of medicine. But in the end, I feel like instead of functional, I'm like, man, I use the word foundational just like you do all the time. I feel like we're in foundational medicine first and foremost, because a lot of women, and I don't blame them, they want to jump right to a pill, whatever that is, right? Like, will progesterone cure this? I'm like,
Right to the
well,
fix. Yes,
right
we
to the
always want the
fix.
fix so quickly. Yes. Yeah.
And I'm like, well, you didn't sleep last night and you had a glass of wine and your stress is
Yeah.
10 out of 10 and you skipped
Ergo.
lunch and you live on caffeine and you have, like you haven't had enough water. So I joke, I'm like, we are like house plants. So it's the basic questions. Have you had enough water? Have you had any sunlight? Have you had any fresh air? Are you in a good environment? Are you like a plant? Do you have a nice window to sit next to and enjoy? Are you a happy plant? Are you a sad plant? Like these are the things that I think we hear all the time and they're boring and we're like, yeah, I know that. But what hormone is going to fix me, or what pill or what supplement is going to make this better? And it's those foundations of hydration, nutrition, sleep, movement, community, joy. That's really, truly why we call it a foundation. Because if those are messed up, I could give you any pill in the world and it's not really going to help you.
Have you seen the shift in your own life in how you approach those foundations?
Yes, because now that I've gotten older, I'm in my mid to late 40s, the things that I could get away with in my 30s or even early 40s, I surely can't get away with anymore. And I feel that I have really solid foundations. And even having the foundations, being perimenopausal, I'm getting the symptoms. And so I know it's a balance between you have to have all the foundations dialed in and you can totally have the hormonal support or the supplemental support or the medication support, whatever you need. But if I didn't have my foundations dialed in, I know my journey would have been a lot rougher. I know my symptoms would have started a lot sooner versus having the occasional. I'm warm occasionally. I don't sleep occasionally now. I'm moody occasionally versus hear it from women directly out of their mouth. I see it right in the comment section of social media where it is every day, all day, taking over their life. And so I have found that I've had to adjust prioritizing sleep, completely cutting out alcohol, prioritizing protein, changing how I work out to include a lot more heavier weightlifting for me, as opposed to just getting away with cardio or walking, etc. And so some of these changes, it still falls under foundation. I'm just tweaking it for being a woman in my late 40s.
Yeah. And I love that what you said, that these have been elements that you have had in your life, but now because of that severe drop in estrogen to almost nothing, now you're noticing more some of these things. And so it can be this, okay, it's time to tweak, right?
Yeah.
This is the tweaking generation.
Yes.
Not twerking, but we're tweaking. And I
Yes.
right. And I think sometimes we think, oh, this shouldn't be happening. But yeah, I look at myself too, who similarly have dialed in my sleep, my alcohol consumption, my nutrition, my fitness, my wellness, mindfulness. Those things I have been practicing for years and years.
Mhm.
However, as estrogen has dropped, progesterone, right, dropped. Now
Mhm.
it's like, okay, I'm noticing I feel things more palpably, like
Yep.
emotions. I could feel it. It's almost like you feel tears behind your eyes, or you feel, in the middle of the night, you're waking up and you're like, okay, this wasn't happening before, but now I'm going to have to do something a little bit different to tweak this. So
Yes.
what are some of the tweaks that you would recommend? I guess let's dive into maybe the conversation of sleep. This
Mm.
is obviously a very important foundation for us because it's going to impact your nutrition, your how you train, your mindful attention. Like it will impact everything.
Yeah.
So, what are some of the tweaks that we can begin to implement? And feel free to go wherever you like with this, right? Into
Yes.
supplementation, into strategy, into environment, for sleep. Let's talk about that first.
It's all the above, isn't it? I mean, it definitely becomes jokingly like a full-time job. And I understand, I can empathize and sympathize going through all the foundational work. Whereas before you would just go to bed, you'd be up on your computer, be watching TV, you'd go out clubbing, speaking of twerking, and then you just come home, maybe take your makeup off, maybe not, get into bed, it's no big deal. And now, like you have to start at 8:30.
Yeah.
Now you're like, okay, I have this whole routine and I'm gonna make tea and I'm gonna dim the lights and I'm gonna read a book and I'm gonna, set the mood and take my sleep supplements or my progesterone or both, whatever you're doing. And that's truly my life now. I have to be very careful about eating late, especially, heavier meals late, or if I have sugar late. Again, like I said, alcohol absolutely wrecks my sleep. So when
Yeah.
I'm talking with women, I'm like, I know it's not fair or fun, but I need you to treat this like you would treat a toddler. Like I need you to start a routine about an hour before you go to bed. Even does that mean take a bath? Does that mean take a shower and rinse off? I need you to read a book just like you would read your toddler a book. I need
Mhm.
you to have, sleepy time tea. I need you to be calm music, calm lights, just like you would want to like calm your toddler down before you go to bed. And we tend as humans to sleep better in a colder environment, however that looks. If you could open your window, if you can truly change your thermostat. I know a
Mhm.
lot of women that have now fans in their room or turn their overhead fan on to try to cool down the room while they sleep. Sleeping in darkness. So does that mean a sleep mask? Does that mean covering up lights from even the smoke detector light, or if you have other little lights that show off in your room for whatever reason? Do you need to be sleeping with earplugs? Does your dog snore? Does your partner snore? Is it loud outside your window? No, some of these things that never used to bother us now, because we don't have the hormonal, I call it the trampoline. Like we could bounce off the hormonal trampoline and just jump right back up. No big deal. Well, after a time, unfortunately, just with age and stress and hormone changes decline, our trampoline becomes more threadbare. And now
Mhm.
suddenly we're falling through it. The bounce isn't as high as it used to be. And we don't sleep as a result. So we add in all of these hygiene supports as if you were a toddler. And on top of that, I do layer supplements. I am a huge fan of magnesium at night before bed,
Mhm.
magnesium, like glycinate as an example. I'm a
Mhm.
big fan, if it's time for you, doing oral progesterone, like actual bioidentical progesterone before bed. It can be very calming for the brain. I'm a
Mhm.
big fan of the calming herbs. I do calming sleepy time tea before I go to bed. Or you can take them, as capsules or tinctures, such as there's herbs like holy basil and passion flower. And there's one called L-theanine. That's a great one for sleep and calm. And chamomile, everyone's heard of chamomile. Like these are real, these are legit, these are studied and can just layer into your
Mhm.
hygiene routine of trying to get to sleep on time.
Mhm. I like how you said just layer it in because yes, this is the tweak. This is what we're doing. We're
Yep.
tweaking these things. Sometimes, I mean, I find my nighttime routine very soothing,
Yeah.
and if I am out late, I'm like, I'm like anxious to get home and
Yes.
start my whole bath process and my low lights. Yeah, if I'm out somewhere, I'm like the lights are overhead and they're bright. I'm like, oh, don't,
Yeah, I
don't.
shouldn't. I mean, I laugh because I completely relate. My husband and I joke. Like the other night we got into bed. It was like 8:35 when we got into bed. And I'm like, is
Yeah.
this our life now? We get into bed at
Yeah.
8:35, but it was also, of course, super dark outside. It looked like midnight. It was pouring
I
down
know.
rain. It's cold. We were like, yeah, let's go to bed and read. This is great.
Yeah, absolutely. Okay, so that's sleep. What about nutrition? What are some of
Mhm.
the things that you're encouraging your patients to tweak in their nutrition?
A big one, two big things, I guess three. One is protein, and two would be dietary diversity, which I'll get into in a second. And then as part of that would be fiber. So the
Hmm.
protein aspect, and I've seen this joke on social media as well, that I didn't, people will say, like, I didn't realize I need to spend hours a day figuring out my protein now that I've gotten older. And I'm like, I know. However, given the research we know on how we lose our skeletal muscle or lean muscle mass as we get older, just as a result of aging, and because our lean muscle mass is so beneficial for our bone health, and it's so beneficial for helping prevent chronic disease such as metabolic syndrome, diabetes type 2, etc., that we want to preserve our muscle mass as long as possible. We want to stay strong. We want to be able to jump and lift and grip and twist like we were when we were younger. And that really declines as we get older. So when it comes to nutrition, protein, on average, we need 20 to 30 grams of protein, maybe more, depends on your goals and what you're doing at each meal, because that's going to help stimulate muscle growth or muscle synthesis. So to help prevent just the baseline loss of the muscle that you have. And so we want that extra protein as we get older. Now, we also want to get into diversity of foods, which means you've heard it before, eat the rainbow, try new foods. When you go out to eat, try ordering something new. When you travel, try ordering something new. And the reason for that is research shows as women get older, we have less diversity down in our GI tract and all our gut microbiome down there, the little bacteria and viruses and in pieces and parts that make up our microbiome. And so we want to maintain diversity. Diversity is a good thing to help us prevent inflammation, prevent chronic disease, prevent illness, etc. And so in the research, they talk a lot about diversity, like changing it up every once in a while instead of eating the same thing on Monday and the same thing on Tuesday and the same thing on Wednesday. And in that comes fiber. We now realize much more so as women going through the perimenopausal transition that getting enough fiber is truly important for that gut microbiome. It's important for we have a layer in there called the mucus layer, and we have parts of our bacteria that take care of that mucus layer. And if we don't, then it can thin over time and it can allow more viruses and bacteria that we breathe in to sort of get through, or it can allow food particles that we don't mean to get through to the other side, to our bloodstream, which we don't want. That can drive more inflammation. And we want this fiber one to help continue with, make sure we don't get constipation, make sure we have a normal bowel movements, etc. And so we also use this fiber. Some of the fiber is helpful at improving what's called a short chain fatty acid, which is essentially the food for your large intestines, the cells in your large intestine, and that declines with age. And we want to make sure that we improve that health. And so it sounds and it feels initially at least like a lot, but when you realize truly all the changes our GI tract goes through, our skeletal muscle goes through, all of these changes that our systems go through as we make this perimenopausal transition, then it becomes a little bit more urgent of like, oh, I really do need to make these tweaks, because I don't want this to progress due to age or progress due to the loss of these hormones and lead me to chronic disease. I'm trying to avoid that.
Yes, absolutely. We are. I had Dr. Emily Leeming on, and we talked about diversity. One of the great tips that she gave. So if you didn't catch that podcast, folks, one of the great tips was to include those mixed everything. So mixed beans, mixed berries. You go to Costco, buy the frozen berries. That's great. Instead of getting just blueberries, get the mixed. Then you have 3 varieties. Mixed beans, you have 6 varieties. Mixed vegetables, you have 3 varieties. So I loved that as a tip. Or mixed lettuces.
Love it.
Right? Such a good tip. Let's talk about, yes, this transition. And I mean, you've got some great ways of putting this. I've listened to a few of your podcasts with describing the phases of perimenopause, and then you're in menopause for one day, and then you're post-menopause. So can we talk about those transitions and maybe what to expect in each of those stages?
Technically, there are 2 phases to perimenopause. I would argue there's more. If I ran the world or ran that particular workshop where they decided this, I would have colored that up a little bit, but technically 2. So we have early perimenopause, and unfortunately, the whole definition centers around, do you get your period or not, which can be really frustrating if you have a progestin IUD or coil, or if you've had a hysterectomy where your uterus has been removed, but you still have your ovaries. So we're going to pin that. I'll talk about that in a second. But early perimenopause, they say your cycle is changed by about 7 days. So maybe you used to be a 28-day girl and now it's shrunk down to 21 days or up to 35 days. You tend to start to get this in your late 30s, but really more your early 40s. And the most common symptoms that are reported to me are more fatigue, more brain fog, heavier periods, maybe worse PMS, sort of worse cramps because of that change in progesterone in particular. Sleep starts to change here. So this is where women go, what the heck? I'm waking up at 3 a.m., 4 a.m. So those are the most common symptoms I'm seeing at this portion. Then we get into late perimenopause. Late perimenopause is defined as having skipped 2 periods, so going 60 days or longer without a period. So now we're in the skipping phase. So if this is you, maybe you've gone 2 months, 3 months, 4 months, 5 months, you're considered late perimenopausal. As you skip cycles, your estrogen stays low longer. Now you're more prone to worse brain fog, memory recall, hot flashes, night sweats, maybe the vulvovaginal symptoms, what we call the genitourinary symptoms of menopause. So vaginal dryness, pain with intercourse, things like that, because estrogen plays such a big role with that. Joint pains, muscle pains, dry eyes, dry ears, itchy ears, some of these annoying symptoms where you say them out loud and people go, that's perimenopause? Yes, it can be.
Yeah.
So not cool. I don't know who thought of this. So that's considered late perimenopause. I wish there was a gray area in between, but there's not. And then I wish they came up with like maybe an extra late or an almost there or you're so close column, because once you start skipping consistently, once you're headed toward the 12 months of no period, kind of like a Christmas song, the 12 months of no period,
My
then
true love gave to me.
right. Unfortunately, and this is my other joke. I'm like, we don't get anything. We don't get a crown, a
No,
watch, a certificate,
you're
nothing.
just losing. You're losing.
Exactly.
My goodness.
So I wish that was classified where women are like, okay, I have definitely skipped more than 2 months. I'm at the 10-month mark of no period. I'm like, okay, the reason I think this is so important is that's 10 months of having very, very, very low hormone, progesterone and estradiol, unless you're doing something about it. But a lot of women aren't because they don't know to, or their practitioners like, oh, not yet, you're still too young, which is to me ridiculous. So once you've gone 10 months, 9, 10, 11 months, I feel like you're so close, you're almost there. But also I, as your practitioner, would have to work really hard to support you because that's a long time not to have estradiol or any kind of support or to talk to you about foundations in your body. When you hit the 12-month mark, that's the day you're considered menopausal. So you go 12 consecutive months, no period, the 12-month mark, you're menopausal. The next day into your 13th month, you're considered postmenopausal for the rest of your life.
Right.
Now, ideally, you don't bleed again. If you happen to randomly bleed at some point, please always tell your healthcare practitioner you've started bleeding. And if you are in the lead up, let's say you're listening to this and you've gone 10 months with no period, and tomorrow, Murphy's Law, you get your period. You have to start your count over again. I'm so sorry. But I still feel like you're in that like super late, almost there phase that doesn't exist yet, except in my world.
Yeah.
Now, if you've had your uterus removed, but no ovaries, or I'm sorry, let me back up. If you've had your uterus removed, but your ovaries have been kept, you still have your ovaries. You're not surgical menopause. So you've got ovaries, but you're not really sure what they're doing. Or if you have a progestin IUD, let's say you have the Mirena or the Skyla or Kylena, which oftentimes causes women not to bleed, but it doesn't, they still have their ovaries. So they're like, I don't know where I'm at because I don't bleed, right? So then we use a blood test called FSH, follicle stimulating hormone. And in the US, when it's over, depending on what lab you use, when it's over 25, some labs say over 30, then you're considered menopausal. But if you get an FSH and you're in the single digits, you're 8, you're 6, you're 9, you are not, you're like your ovaries are still working. They're doing great. Once you get up into the teens, it's like, all right, you're pretty solidly perimenopausal. And as I said, 25 or 30, once you're over that, you're considered menopausal. So then we have to use blood work for those women.
Yeah, that's sort of what happened to me. I was on the IUD because I had had really heavy periods. And then at 51, I think, I'm like, well, am I in menopause? How do I
Yep.
know even because I haven't had a period for 5 years. And so when I took out the IUD, I had one real big bleed, which I'm like, oh, great, it's back. But that was last October, and now it's this October, and it's been the 12 months. So as of October, freedom.
Yeah, you get a crown or a watch or a certificate. You said something.
Really? Are you sending that to me? I
Yes,
love
that's,
that. I
I would
didn't
love
know.
to. I'll Amazon it to
Um,
you.
yeah, exactly. So, part of my journey this last year is definitely trying to figure out if menopause hormone therapy is right for
Mhm.
me. And boy, it's a noisy space, so it is confusing. And I know a lot
Mhm.
of our listeners have voiced the confusion because there's just a lot of opinions and
Yeah.
everyone's experience is different, which I think is what makes it challenging for each individual practitioner to give advice that it's a blanketed statement, right?
Yeah.
Because
Yeah.
everyone is so different. So you do have to have these conversations. Um, I had Dr. Shafina Premji on as well, and we were talking about my own status as
Mhm.
someone who is non-symptomatic. Like I'm good. Everything feels good. I feel
Mhm.
strong. Bone density on my DEXA scan last year was great. My T zone, Z zone,
T score.
yeah, Z score and T score were both above average. So I'm feeling good about that.
Nice.
So then my question is, yes, who is menopause hormone therapy recommended for? In your opinion, would it be for everyone to stave off the loss of X, Y, and Z? Or will there be some people that just will function really well without it? I'd love to hear your thoughts on this because it's, yeah,
I would say, so this is a great question. And
yeah,
this is purely my opinion because again, nobody can really
sure.
agree across the platforms on hormone therapy. So in general, I am a big fan of hormone therapy. I myself am on progesterone. I'm not yet on estrogen, but I do take progesterone capsules at night in my luteal phase. So in the second half of my cycle, I don't, and I still cycle regularly. So I'm still in that part of my transition. When it comes to estrogen, I would say the majority, when you look at symptom percentages, it's oftentimes over 50%, meaning like who doesn't sleep well? It's like 82% of women. Like who develops, I was just reading heart palpitations. Like 52% of postmenopausal women develop heart palpitations. It's who develops fatigue. It's like 74% of women report their fatigue or what anxiety. It's these huge numbers. So it seems these symptoms affect a large percentage, which is why the guidelines and the societies say when you have these conversations, we see all the percentages and the guidelines are it's individualized to you. So if
Mhm.
you're doing great and feeling great and we're monitoring, your symptoms, your heart, your bone, etc., and you don't want hormones, that it's totally your choice. That's fine.
Yeah.
I
Mhm.
have other women that are like, no, I want hormones because I don't want to cross into any symptoms and it's too late to cross back out. Like, I don't want to come to you in a year, Carrie, and say, now I'm getting brain fog. Now I have vaginal dryness. Now my ears itch. Now I think I'm depressed, but could I have avoided that if I'd started hormones? And the answer is we'll never know because, you're one person and, we didn't do it. So I'd say
Yeah.
the majority of my practice wanted to go on hormones of some sort. The majority of my friends and colleagues at this age are on hormones of some sort. It depends on them as a person. And when I start hormones, I'm always thinking of the symptoms and signs they're having right now today
Mhm.
and trying to prevent what I know is coming potentially in the future. The longevity experts call it the four horsewomen of the apocalypse. So, right. So it's cancer. Here's what we're trying to prevent.
Yeah.
Cancer, we're trying to prevent cardiometabolic, so heart, diabetes, etc. We're trying to prevent neurodegenerative, so dementia, Alzheimer's, etc. And we're trying to prevent diseases of frailty, so bone loss, osteopenia, osteoporosis, break a hip, etc. So I'm thinking today in the moment, what are your risks? What do you have going on? What's your blood work look like? What's your lifestyle like? All these markers. And what's going to happen in the future? Do I know your genetics? Do I know your family history? Things like that. And I know there's a critical most of the research says you want to start within 10 years of your last menstrual period. Don't wait until you're 75 or 80 or, 65 to decide like, I think I might want to go on hormones. The most bang for your buck is sooner rather than later. But I fully understand not all women want to or even a candidate for, but I don't want women to not have the option or get the education that they're just deciding because of their own fear or because of, something they read incorrectly on social media. Like I want women to understand, here's the deal on hormones. Here's the ideal time to take them. Here's what we're using them for. And then let's make a decision together.
Mm-hmm. You said cross into symptoms, that this is what you want to prevent, is that if we're not taking them, that we potentially, given our history and background and maybe hereditary symptoms or genes, we get to a spot where we can cross into some things like osteoporosis or osteopenia.
Because they're symptomatic most of the time, right? So I just want to throw that out there. Like I'll give you an example. I've had 2 or 3 in the last month, women who in their 50s, not on hormones, say to me, hey, I went and got my cholesterol checked. I have no symptoms other than my triglycerides doubled, my cholesterol went through the roof, my blood pressure is now high. I don't know what happened because I'm not having symptoms. Like, oh, estrogen actually, obviously genetics can play a role, but I already knew their diet and lifestyle, and it wasn't that. I said estrogen actually can play a role in all of that. I've had 2 or 3 women, again, like I said, I was talking to an osteoporosis expert, Dr. Doug Lucas, and I said, do you find a lot of women get told you're having bone loss, osteoporosis, and it's a shock to them? And he's like, yes, because it's not often symptomatic. You're doing great, feeling great, and then poof, they go for a routine bone scan and find out that their bones are not doing well. No, you've had your bone scan and you're above average, which is fantastic. But I do want women who are listening to know some of these are very asymptomatic. So just because you woke up feeling like a 10 today, let's keep that up, but let's also monitor. Let's also do some blood work routinely.
Yes.
Let's get your bones checked. Like, let's do these things routinely and make sure.
I know Dr. Premji sits on the menopause board here in Canada, and she said that hormone therapy is not indicated for the prevention of osteoporosis in Canada, but it is in America, in the United States. I'm not sure if it is in Europe. I know we have a lot of listeners over there as well, but how can we have that difference? Why? Like that's
I don't know. They didn't put us in charge.
Yeah. I know. It's like you folks did one set of studies, we did another set of studies, and now they're contraindicated. So who's right in that? And what does hormone therapy, I guess, potentially do to benefit bone?
A lot, right? A lot. We know that bone have receptors all over them for hormone, particularly estradiol, but progesterone and testosterone as well. But speaking of bone, again, when talking to Dr. Lucas, the osteoporosis expert, when he's working with patients, he's like, it's not just hormones. It's the foundational. It's a 360 approach. He's like, we work with their gut just as much as we work with their supplements, as much as we work with their blood sugar, because we know that really affects bone degradation, just as much as we work with the type of exercise they're doing and hormones. I actually asked him in his practice how many women are on hormones, and he had to stop and think. He reversed it. He's like, I actually have to think if there are any not on hormones. He's like, it's such a huge part. Now, again, it's not the only thing these women are doing. They do a whole program in his clinic. It's the same like with cardiovascular disease. Estrogen hormones are not indicated as a primary treatment for cardiovascular disease, which I totally get, but the primary and part of the plan are 2 different things. If you start early enough and you're doing the diet, the exercise, the other things, supplements, medications, it can be part of the plan to reduce risk. And I feel that's where being somebody who's in more the integrative space, that I'm looking at that 360 picture, the holistic with an H and holistic with a WH. Like I'm looking at the whole person and holistically at the same time. And because I have that training, I understand that the guidelines, they're very conventional. They're reading the studies and they state what they feel is best given the research out there, and then we can just add to it.
What are the risks then of supplementing with hormones?
So when you look, so the UK has these really great graphics. They have the National Institute for Caring and Excellence, NICE. Nice. That's what the acronym is. And these great graphics of like little people, and then they color them in to show you like the risk for breast cancer. And so they show you in the combination out of the Women's Health Initiative that of 100 little people on the graph, like the little tiny amount of a person, that the risk for breast cancer if you do the synthetic estrogen, synthetic progesterone combination. If you do oral estrogen, you swallow your estrogen, there is a slight increased risk for what's called a venous thromboembolism, which is a clot, or stroke. It's not a huge percentage that has been, I feel, blown out of the water, but it is a small percentage. It is higher than if you were to do a topical estrogen, such as a cream or a patch. The NICE group out of the UK says there's no risk, that there's no increased risk if you do topical estrogen. But otherwise, when you're reading their little people, they show, like hormone replacement improves, mood, it improves bone, it improves sleep, it improves quality of life. So it's really cute to see like 50% plus of these little people shaded in of like, how does quality of life? It's like, oh, 50+%, report
We like our
great
chart.
outcomes. We like our visuals here.
We like our visuals.
But
I'll try to pop that up on the screen here as well.
But breast cancer is definitely the one with I understand is the biggest concern. And again, the studies on it's the combination synthetic estrogen, synthetic progesterone, which is a progestin, has the slight increased risk.
What was the name of the chart again?
NICE, I can send you the link too. The National Institute for Caring and Excellence, UK's NICE. Yeah.
Okay. Yeah, I'll share that in the show notes, everyone, just so we can take a look at the little people.
The little people.
Colored in. Your podcast is called The Root Cause, which I loved that. And I would love for you to, share with us why you called it that and why getting to the root cause is really important in medicine.
I find, and you probably do too, and everyone listening has probably found that the root cause is definitely not traditionally gone after. If you feel terrible, you're having all these symptoms, oftentimes you go to your GP and they were like, here's a medication, here's an antibiotic, here's a thing, or we don't know what's wrong with you, or that's normal. That's what happens when you have 2 kids under 10. That's what women go through. This is typical, instead of digging deep to find the root cause. So we named the podcast the Root Cause Medicine Podcast to remind people, like, can we keep digging? Do you need to dig a little further? Do you need to, let's talk to these experts in what their area of expertise in root cause medicine is and how to find it, how to test for it, what to do with it. And so we like the title, again, just as a reminder for people, like, let's get to the bottom of what's going on.
Yeah.
As best we can.
Yeah, for sure. And that might take a number of visits, right?
And it might take new practitioners, which I'm okay with. I tell people, if you hired a painter for your house and they did shoddy work, like, you wouldn't just keep going back. You wouldn't just keep hiring them again. You would say thanks, but no thanks. And you'd find a new painter. It's the same in medicine. If you don't resonate with your practitioner, like anything, thanks, but no thanks. And you're welcome to find a new practitioner, or you're welcome to add to your medical team.
Yeah,
if you
your team. That's right.
Yeah, if you love your OBGYN, but they're not great at hormones, totally fine. Keep your OBGYN and then also find a hormone expert as an example.
If only that were so easy in Canada.
I know. I say it like it's like a dime a dozen. I know.
We have wait lists for every physician here, so it's tricky. But yes, it's good that there's lots of information available for free on the internet, and we can find our support, our community within those profiles for sure. So you talk about, going and ensuring that you have the right labs and ask, that there is oftentimes a root cause. So what sorts of questions can we ask the person that we're working with to test for? What do we need to check? What do we need? What kind of background do we want to be looking at in terms of our labs?
With women going through this perimenopausal journey, the great thing is you don't actually have to have a lab test to determine if you're perimenopausal, unless you're in that caveat who, again, we said you might need to get an FSH to test to tell where you're at in the journey. But there's no test that says, yep, you're perimenopausal. It's usually age, symptoms, and what's going on with your cycle, and we can decide from there. However, depending on what your symptoms are and your goals, it can be important to remind your practitioner, I'm this age, or I'm perimenopausal, or I'm postmenopausal. Here's what's going on, so they can decide, is it appropriate to check your hormones? Maybe we do want to know what your progesterone's doing. Maybe I want to know where your testosterone is at, or your DHEAS. Now, on top of that, a lot of these other hormones, we have over 100 hormones in our body, can go haywire at the same time. And I'd hate for you to miss it and just blow everything off as estrogen and progesterone. For example, we want to make sure you're getting your thyroid checked. We want to run a thyroid panel, TSH, thyroid stimulating hormone, free T4, free T3. And especially if you have autoimmune or an autoimmune history or autoimmune in your family, let's check the autoimmune markers for thyroid as well. Some of these symptoms overlap with anemia. You may be low in iron or B12 or folate. So let's do some additional work in that. Let's check your vitamin D status if we can. Let's look at your red and white blood cells. I already mentioned your lipids. Let's do a full cholesterol panel. I want to see what's going on. And I want to do it yearly at least, because what can happen is women go, no, I just had that done like 3 years ago, 5 years ago. My whole life, I've never had a cholesterol problem. I'm like, I know, but you've also never gone through perimenopause. So
Yeah.
let's keep an eye on that.
Don't a lot of women get a bump in their cholesterol levels in this phase?
A lot. I've
Yeah.
had a lot of cardiologists and lipidologists pull me aside at conferences and say, my practice is made up of women who shockingly hit perimenopause or menopause, and their lipids went through the roof. And they never had high cholesterol before. They don't know what they did wrong. I'm like, you didn't do anything wrong. It's this whole transition can affect your lipids, your triglycerides, your glucose, your insulin, some of these other lipid markers, apolipoprotein B. And the great thing is they're readily available to test. And everything I've listed off is not special. It's not unique or weird or rare or taboo. They're pretty common labs that any lab can run. And I hope as we get more research in women's health, they will become far more standard. Some of them are standard. You can get a lipid panel, you can get glucose. But to get a little further, insulin, not everybody runs an insulin, but you should be able to. It's very easy. Vitamin D, oddly, there's a lot of debate and controversy around that. You should be able to run that. B12, very cheap to run. So some of those markers, we want to make sure that we're evaluating.
Yeah. Don't you have a little handout or a free giveaway?
I have a labs checklist. Yes,
Okay.
where I kind of break through let's call them levels, like the basics, like you need a little more advanced, and then what's the really cool, then there are cool, tricky labs out there. Like at what point do you need the cool labs, the more expensive labs?
I think that would be very helpful for our listeners. Just, to get that link, take it to your doctor and see what you need to be asking for.
And it's okay to argue. Maybe argue is not the right word, although sometimes it feels like it. It's okay to be confident in your decision to ask your practitioner, for example, I'm 50 years old and I would like these markers, and here's why I would like them. Yeah. Because even my own OBGYN, as much as I like her as an OBGYN, I said, I need cholesterol checked. I need this. And she was like, why? You're so healthy. I said, but I'm 47. I would like to know. It's been a while. It's been a couple years since we've looked at this, actually. Let's do it.
Yeah. And a doctor seeing a doctor, that might, that's a tricky conversation in there.
It is a tricky conversation.
You know exactly what she should be saying to you. But sometimes it's nice to see things through different lenses. And this is why we go.
My OB is a lot younger than me. She's still in the baby making phase. She was pregnant last time I saw her. And so she was not even thinking about the fact that I was close to 50.
Yeah. Well, I think going to the physician, it sounds like a really good time to go I mean, always regularly, but a lot of us don't. A lot of
Hmm.
people put it off because they feel okay today. But if you have stopped having your period and maybe you've gone 2, 3 months, it might be time to go, okay, it looks, and you're in this specific age range between what you say about 42 and
Yeah.
52.
Yeah.
Yeah, that it's time to go and get your checkup and make sure that everything's going as it should, and then to have these conversations about what hormone therapy might look like for you if that's a road you want to go down.
Exactly. Especially again, as we're seeing more and more research out. For example, I already mentioned the genitourinary syndrome of menopause. So that's everything in the lower regions that can happen because of the loss of hormone. We know the treatment, if you're a candidate, most people are though, is hormone replacement. You can use vaginal estrogen as an example or vaginal DHEA. A paper has come out this year, 2024, talking about the musculoskeletal syndrome of menopause. And it
Dr.
centers
Vonda?
all around Dr. Von der Wright, all around estradiol. And so, but what happens is women get told, like, we'll take pain medication, try this over-the-counter pain medication for your shoulder, try it for your sore muscles. And Dr. Wright was like, we know it's estrogen. Like, what? Here are some supportive things we need to do, and estrogen is a part of it. She outlines it in the paper. And
Mhm.
we now are seeing the depression. I'm seeing a lot more research on depression and the going through menopause, and how the foremost treatment should again be estradiol and or progesterone, because what happens is a lot of women get offered antidepressants, which may or may not be very helpful, but that's not the issue. The issue is that they're missing the estrogen,
Mhm.
estradiol, and even progesterone, which plays a role in anxiety. It reduces anxiety. So why not just do that? So I'm loving that these syndrome papers are coming out saying actually the forefront support should be hormones if they're a candidate, because that's the root cause of where we're at.
And there's the root cause again.
Yes.
That's good. That's good. Well, this was a very enlightening conversation. Thank you so much for joining me. I would love people to follow you because I think you're a great wealth of information. Where can they follow you on social?
Oh my goodness. I'm on Instagram mostly at dr.carriejones, but I have dipped into TikTok. Wish me luck. I am at Dr. Carrie Jones there as well, and on YouTube at Dr. Carrie Jones.
Yes, I have listened to a number of her YouTube. I love doing that in the morning when I get ready, put my makeup and do my hair. I'm always watching, listening to a podcast on YouTube. So I did consume a bunch of yours, and it's funny and fun and lighthearted, but so informational. So make sure that you follow Dr. Carrie over there.
Well, thank
Well,
you.
thank you for being my guest today. To all of you, now go move daily in your fitness, wellness, and nutrition. And we'll see you all in the next Move Daily Talks.